I'm going to talk about the cornea dynamic and tomographic analysis for pre-refractive surgery screening. So we all know that it's a nightmare if you have a case developing corneal ectasia after refractive surgery. So studies have shown that abnormal preoperative tomography is the most significant risk factor for the risk of developing ectasia. And most people will believe that people have keratoconus actually predispose patient to develop corneal ectasia after refractive surgery. So what we want to know is to have an early diagnosis or screening of subclinical keratoconus in those cases to avoid them to having refractive surgery. And so right now we have the rotating Scheimpflug-imaging, which is the Pentacam, that can help us to provide tomographic data for diagnosing the disease at a much earlier stage. So this is one of the printout of the Pentacam, which is the Berlin Ambrosio enhanced display. And you can see they have many different parameters. And usually we will look at the parameter at the bottom, which include the analysis of the anterior corneal surface, the posterior corneal surface, the change in the corneal thickness, and also other parameters such as the ART max, and they will finally give you a final D values so that you can try to evaluate if the cornea is fit for doing any refractive surgery. And the enhanced BFS is actually when they calculate the best fit sphere, they eliminate the most abnormal part so that you can see if we, in the bottom graph, if we eliminate the bulging area, the result will be much more prominent. So this helps us to detect very minimal change of corneal ectasia. And another thing is the corneal thickness spatial profile, which is like a growth curve for baby. For example, if the cornea is getting thicker and thicker from center to peripheral at an abnormal rate, it will show up in this graph. And we believe that most cornea has a pretty much similar rate of changing corneal thickness from the center to the periphery. And another thing is the Ambrosio relational thickness. It is a parameter which is the topographic progression divided by the PPI max, and it has been shown to have a 100% sensitivity and specificity in discriminating keratoconus from normal cornea. So this is a very good parameter. So these 5 parameters are those that I just mentioned. So the DF is for the anterior front surface, the DB is the back surface, and the DP is the pachymetric progression, and the DT is the minimal thickness, and DA is the ART max. And they will give you a total deviation values, and the values will be color coded. And if it is within the 1.6 to 2.6 standard deviation from normal, it will give you a yellow color, meaning caution. And if it is more than 2.6 SD from the normal, it will turn in a red color and indicating a pathologic reading. So in the literature, people have shown that ART max and the final D value of the BAD has an area under curve of more than 0.95 in diagnosing keratoconus, and an AUC of 0.92 in diagnosing subclinical case. And the final D value is found to have a 89% of sensitivities. And another group also showed that the final D values of BAD had 100% sensitivity and specificity in discriminating normal eyes from keratoconus. But how about for the foam flux case? Because actually I believe that we don't actually need a topography to diagnose keratoconus, because keratoconus can be a clinical diagnosis. You can look at the slit lamp and look at all the features. But what we want to know is those foam flux case. That means those who has the potential of developing keratoconus. So studies have used this term to define a cornea that has no abnormal clinical or corneal tomographic finding, but their fellow eyes has a clinical keratoconus. That means a unilateral kind of keratoconus. And studies have shown that, some studies actually show that the BAD and ART is not as great as the tomometric method, which is the IVA and the IHD. But previously we published an article that Michelle has just mentioned, is that we find that the BAD has an AUC of 0.76 in detecting those form of case. Although the sensitivity and specificity, the sensitivity is around only 53%, but we have a high specificity. And this paper has been published in the JRS. And so it seems that the tomographical means is not sufficient to diagnose keratoconus alone. So that's why we have another machine that can measure the corneal biomechanical properties. Because we believe that corneal biomechanical failure is the basis of keratoconus. So a device such as the Corvis can measure the change of, let me see if we can measure the change in cornea shape. Oh, it cannot be played, but it's okay. I can measure the change of the cornea shape with an air puff, so to acknowledge those biomechanical properties of the cornea. And it has a lot of different parameters that I cannot explain it now because of the time limit, but they have different phase. And studies have shown that the deformation amplitude, which is the amplitude, the red one from here to here, the deformation amplitude actually has the highest area under curve in differentiating keratoconus from normal, and the AUC is 0.882 and with a high sensitivity and specificity. And another study also find it the DFA, which is the deflection amplitude, which is similar to the deformation amplitude. They find that both are very good at differentiating keratoconus from normal. But however, as I mentioned, you don't need this machine to diagnose keratoconus, because keratoconus can be a clinical diagnosis. So that's why and actually previously studies have tried to match patients with similar corneal thickness and intraocular pressure, because those two values may affect the diagnostic capacity of the machines. And people have matched those and find that the diagnostic capacity are quite good of using the deformation amplitude of the Corvis. And in a previous study, we actually utilized a newer beta version of the Corvis, and we find that the area under curve is much higher using a single value of DA ratio 2 and DA ratio 1, and this has been published in BJO. And later on, a study has published the use of the SPA1, which is a low-flow corneal stimulant parameter. And with these parameters, with the Vincent-Kruller group, formulate the Vincent-Kruller screening report, which show the different Corvis parameter, and also in here they will give you a so-called the Corvis biomechanical index, which is a range from 0 to 1, and it is also color-coded. And so this figure actually explains the different explanation of different value, thanks to Skyview, about who makes this very nice graph. And how about the literature? And actually, the CBI has been reported to have a high capability to diagnose keratoconus from normal with AUC of 0.99. And in our previous study, we also found a similar AUC. But how about for the Form-Fox case? Michelle actually the previous speaker has told us that our result actually show a quite good AUC with a comparable non-significant AUC between the CBI and the BAD. So we find that biomechanical values can have a similar diagnostic capacity compared to a tomographical values in those cases with subclinical or Form-Fox keratoconus. But however, you can see the sensitivity and specificity is not that high in both of them. So those on the graph on your right show that the sensitivity and specificity, and this is the AUC curve of these two values. So maybe what we can do is to combine the two things together and to analyze it, and it is called the TBI, and so the TBI actually include the Corvis parameter and also the Pentacam parameter, and it will give you a tomographical biomechanical index. And so this is one example of a unilateral keratoconus. You can see the left eye is definitely abnormal. The right eye tomographically it looks normal. But when you do the CBI, it is quite high, 0.94, and they give you a very abnormal TBI, so that means it is an abnormal cornea. And their study that's shown that it has a very high area under curve of using the TBI compared to the BAD and the CBI. And we actually conduct a study in CUHK, and we also compare cases with subclinical keratoconus and normal. And you can see those anterior K-mean, the BFS are very similar between the normal and the keratoconus suspect. But we find that for the when we look at the area under curve, we find that the area under curve for the black one is the TBI is much higher compared to the red one, which is the BAD. So that means combining the two parameters, the BAD and also the CBI will improve the diagnostic capacity of differentiating subclinical case. So that could definitely help us as a refractive surgery, because this helps us to screen people with potential development of ectasia. So actually I have some examples to show today. So these are my case. So this is a patient who come for a refractive surgery, and the tomography is like this. And the BAD, we only find an abnormal cornea front of a DF of 1.75, and overall they are normal. And then I try to do the Corvis for this patient, and we find most of the parameters are abnormal. And later on, the TBI is 0.62. So in this case, I advise the patient to monitor it for 3 months, and then I will repeat the examination. But unfortunately, this patient also got a high TBI at that time, so I asked the patient not to have refractive surgeries. And actually, she is very grateful to me, because she believes that if she had the surgery, there may be ectasia developed later on. And I have another case also here. So you can see this, let me see. So this is another case, and the CBI, the BAD and TBI are normal in one eye. It's normal for the left eye, but it is quite abnormal of the left. It's still normal, although the CBI, here I want to show is the CBI, although it can become abnormal, like around 0.50, but however, the TBI is still normal. And in this case, I will still proceed for the surgery. And this is another case. And you can see there are 2 yellow spots in the D front and also the ART max. And however, the CBI is very abnormal in this case. And you can see in this case, the CBI is very high and the TBI is very high. And this is another case too. And so it is so although I saw so many cases of abnormal TBI, but fortunately most of the cases are normal. So these are some examples that I show that show a suboptimal BAD, but the Corvis will definitely help you to make sure if the cornea is normal or not. And so in the future, we believe that combining the two properties can provide a safer and more efficient refractive surgery screening. And thank you.